Hello, my name is Bill McNair, and welcome to our Post Fall Huddle video. Um, Today we have in attendance myself, Joon's nurse, have the CNA that was assigned with me for this patient, charge nurse for the floor, the house supervisor for today, an occupational therapist for our floor. We have Joon and the family. So we conduct these meetings so that we can assess why patients have fallen and what we can do to help prevent this in the future. So the first thing we do when someone falls is obviously we take care of them, but after that we do a Morse Fall Scale. We also do this for patients that might be at risk of falling, so to help us get a better idea of who might be at risk. So number one on the list is a history of falling. If they've fallen immediately in the last 3 months, obviously he just fell, so they get positive on that, 25 points. Secondary diagnosis is you have 2 or more medical risk factors. The UTI currently and the dementia, I would say, is a positive on that one. So that's a 15 points on that. Does the patient use any ambulatory aids to get around? Daughter says that he uses furniture instead of his walker around the house. So that's a 30 on that scale. Does the patient have an IV or a heparin lock-in currently? And he does. He has a IV in because he gets the IV antibiotics for the UTI right now. So that's a 20 on that one. Gait or transferring, is he weak or impaired? That one I wasn't sure about, so I put down weak, and that's 10 versus 20. It's not that big of a difference, but I gave him 10 there. Mental status, is he oriented to his own ability, or does he forget his limitations? And with his dementia, his daughter says that sometimes he forgets he has dementia and forgets he can't walk as well. So we give him 15 for that. The total on that is 115 points, and that falls under, there's different no risk, low risk, or high risk, and anything over 51 is considered high risk, and so we need to implement high risk fall prevention interventions for him. So Joon says what was he doing when he fell? Tells me he was using the restroom, and he was just tired of waiting for staff to come in. They pushed the call light, couldn't wait any longer, had to go. So obviously at some point he fell. I'm not sure exactly why he fell, if he tripped over something or wasn't using the walker, but he fell. So what can we do to make changes to his care plan to help prevent this in the future? Number one, making sure that the path to the bathroom is free of clutter, including furniture, oxygen tubing, IV poles, blankets. Make sure the floor is not slippery. Also making sure the family understands that if he's going to use the bathroom and they're in there with him, make sure they do get anything else out of the way, bags or chairs or anything like that. So make sure the patient does have easy access to things like canes, walkers, non-slip shoes or footwear or socks. Using a bed alarm possibly. If he's not able to use the call light or forgets to use the call light, the bed alarm may alert staff that he's gotten up out of bed without help. So having aids like maybe a bedside urinal. If he just has to urinate, that might be the quickest, safest, and easiest way to allow him to do that without asking for help, or if he's waiting too long for help. So maybe have occupational therapy help him with ways to get out of bed properly, use his walker properly. Maybe he just doesn't know how to use it properly and gets tied up in it sometimes. So if his dementia is really bad, we might want to consider a sitter when family's not there or staff isn't around all the time, or maybe closer to the nursing station so we can kind of keep a little closer eye on him. So is this a system-wide event? I would say possibly. I don't know what our overall fall happening is, but it's something that we can address as a system, or make sure that those things are in place, and those things that should be communicated to other departments. This reminder that all patients should be wearing non-slip footwear or socks. Patient rooms, whenever somebody leaves the room, need to make sure that there are free of obstructions or things on the floor that are going to get in the patient's way if they get up and around. Make sure that patients have their call bell available, and anything like a walker or cane that they are going to use to get around is right there for them. How can we share this with the other staff? Onboarding training, obviously people come in, are new employees. We can make sure that they understand the fall risk for any patient, but especially those that are high risk. Periodic in-service training, it's something that, needs to be hammered home. Patients that fall and break a hip, our life expectancy is generally less than 2 years. Now, a lot of these older patients have other comorbidities, but we need to make sure that we don't put those patients at much higher risk for continued problems. So, and of course, my CNA and I are going to talk about what we can do personally in the future to prevent this. So, obviously, with Joon, we're going to make sure we implement standard fall preventions. Make sure he's wearing the footwear. We're going to probably use a bed alarm with him. Is it long-term sustainable? I would say so. Our hospital has a pretty good policy of making sure everybody wears non-slip footwear. Even our patients that aren't at a high risk, everybody wears the grippy socks, regardless. So, other than that, if anybody has any questions, I welcome them. If not, thank you for coming to our Post Fall Huddle.